Very prestigious conference growing year after year, and everyone is looking forward to be part of such a good feast. Task they've assigned to me is defining atherosclerotic cardiovascular risk assessment to individualize therapy in primary prevention. Well, flow of my session will be first what is exactly atherosclerotic cardiovascular disease and what is the magnitude in diabetes, pathophysiology, how we can do a risk assessment, therapies to address the risk, and evolving algorithms to address this issue of atherosclerotic cardiovascular disease and management of type 2 diabetes, and whether there is an evidence to prove that if you go with this algorithm, this makes a difference in terms of overall outcomes. I'm sure you all know that diabetes and cardiovascular disease, they have a common soil hypothesis. Not only diabetes increases risk of CVD by 2 to 6 fold and overall death also, at times, atherosclerosis may precede development of type 2 diabetes, and both share a common genetic as well as environmental antecedent factors. That is how it's a common soil hypothesis, and it is possibly something to do with insulin resistance, which could be implicated. Wonderful ERIC study, a data of about 11,000 black and white subjects in this trial, what is known as atherosclerosis risk in communities, and they were followed for a median period of about 14 years, and you could see as there is a little increase in HbA1c, not very high HbA1c, just an increase about 1.5%, that makes huge difference in terms of overall coronary artery disease prevalence in these patients. Again, in this prospective study collaboration and Asia Pacific cohort studies collaboration, they've shown that diabetes increases risk of occlusive CV mortality by more than twofold, and it is independent of major CV risk factors, and more so in the age group between 35 to 89, you could see that hazard ratio goes up by almost 2.3 versus a placebo. And all patients this is a trial of about 4,000 patients who were referred to cardiologists for coronary artery disease evaluation by angiography, and done in about 110 centers across 25 countries. And 50% of patients with CVD or CAD, they had evidence of insulin resistance, and they have already excluded all those who were known diabetic or IGT. That means still 50% had an element of dysglycemia. Even Framingham Offspring study said as early as 2007 that 2/3 of diabetics, they have subclinical CVD which may not manifest. You need to look for that. Diabetes increases risk of subclinical CVD by almost fourfold, and what is much more important is that if you have a non-manifest subclinical cardiovascular disease, it increases overall CV event rate by again 2%. A very good comparison versus Caucasian, that South Asian, they tend to have coronary artery calcium at much higher rate. Almost 2/3 patient they have coronary artery calcium already, 120 patient compared versus Caucasian, and 30% blockage was already seen in about 75% of patient, and more than 50%, which could be said as a significant CAD, was seen in about 40% of patient versus Caucasian. So that brings us to a point that possibly diabetes is no more an endocrinopathy. It is more like a vascular disease where endothelium-mediated vascular health is unbalanced, and you could see a vasoconstriction, growth promotion, a sort of prothrombotic state. That is why these patients, they tend to have much higher cardiovascular risk also. And this is what we propose, that mechanisms of hyperglycemia-induced endothelial dysfunction could be through various pathways. It could be glucose autooxidation, polyol pathway, protein kinase C activation, or advanced glycation end product, which induce oxidative stress. There is an endothelial dysfunction, increased angiotensin 2 levels, and F kappa beta go on the higher side, and there is a increased plasminogen activator inhibitor activity, which induces not only vasoconstriction, inflammation, and rampant atherosclerosis in these patients. So it is hyperglycemia along with insulin resistance, which induces endothelial dysfunction. Smooth muscle proliferation happens, and that is how there is a rampant atherosclerosis seen in these patients. So if you follow atherosclerosis timeline, in the first decade itself, you start having foam cells as well as fatty streak formation. Subsequently, by third decade, you have intermediate lesion or an atheroma coming as early as when you are 25 or 30 years old, and subsequently, by the time you are 40-year-old, there is already a fibrous plaque. which could rupture and lead on to acute catastrophes. What we have seen in very young patient suddenly dying of a acute coronary event. So let me say that it is a continuum of CV risk factor. Classically, it is said that macrovascular complications start much earlier and microvascular, they only come after the onset and they follow a very, very linear relationship. But both the micro as well as macrovascular complication, they have sort of different pathophysiology, because micro are propagated primarily by poor glycemic control and uncontrolled hypertension. Of course, there is a genetic clustering. Many Indian patients will have diabetic nephropathy coming in the families much earlier than anticipated, while for macrovascular, it is more of a heterogeneous situation, not only glycemic control, but lipids, maybe underlying insulin resistance, inflammation, obesity, of course, uncontrolled hypertension, and habits like smoking could predispose to macrovascular complications. So we say that there is a strong link between micro as well as macrovascular complication, which should be viewed upon as a continuum. This is what we propose in one of our publications in IGM, that micro and macrovascular complication in diabetes are no more distinct, and it should be viewed upon as a continuum of the same phenomena. Having emphasized on that there is a strong element of subclinical atherosclerotic cardiovascular disease, let's see how we can prevent and what we can do at the population level. At the primordial prevention level, where we need to address both traditional as well as a non-traditional risk factor. Traditional are typically age, family history, hypertension, dyslipidemia, and diabetes, which is very, very important. Then we talk about primary prevention so that we could sort of prevent the onset of subclinical atherosclerosis in these patients and preventing PVD, maybe coronary artery disease or a stroke or TIA. Subsequently, as disease manifests, then the attempt is to have a secondary prevention so that we could prevent recurrence of these events. So approach which we should follow in the clinical practice is that we should try to assess these CV risk factors in the form that A, B, C, D, E, assess for traditional risk factor, then look for base risk factor estimation via population-based risk factor profile and scoring, and then we consider non-traditional risk factor markers which are available, which can predict that patient has significant cardiovascular disease, and there are non-invasive methods to address that also, which I'll be alluding, and then develop a personalized risk profile based on all these evaluation. Try to engage in the clinical patient risk discussion and then try to practice those guidelines. That is how, based on the evidence, every year you are seeing that guidelines are evolving in terms of pharmacotherapy and in terms of hierarchy. A lot of drugs have come up last 3 or 4 years. A, I told you, is to assess traditional risk factors, and it is primarily based on Framingham Heart Study, where important risk factors identified by Framingham study are age, male sex, hypertension, dyslipidemia, smoking, diabetes, and of course, a family history of premature atherosclerotic cardiovascular disease if it happens less than 55 years for males and less than 65 years in females. Diabetes, unfortunately, has not been considered as a CVD risk equivalent. Earlier, there was, in fact, this debate has been going on. Earlier, it was said that it should be taken as a CVD risk equivalent, but that possibly evidence has not sort of substantiated that. That is why guidelines like ATP3 guidelines, they are still not addressing the issue of diabetes. They are talking about other risk factors like gender, family history of premature coronary artery disease or smoking habits or hypertension, but they are not still considering that diabetes could be a major risk factor. Coming to the B, which is base risk estimation based on population-based risk score. Hence, many modules are now being designed or engines are being designed, especially for diabetic patient. And this is one of the commonest engine which is available, that is UKPDS risk score. What it emphasizes age at the time of your diagnosis. Of course, other conventional risk factors are the sex, ethnicity, smoking habits, HbA1c mean value, systolic pressure, as well as dyslipidemia. Another Q risk score, which is again very, very popular. Again, it is based on the fact that if you have type 1, type 2 diabetes or none, because that is an important emphasis. Others are, of course, age, sex, and smoking status, as well as a early family history of coronary artery disease. Then I told you there are non-traditional risk factors, which we consider as C, which we need to identify. These could be like metabolic syndrome, certain patients having certain markers of inflammation positive, having autoimmune disease or gestational syndromes are available, or there could be extensive comorbidities which need to be addressed before talking about any guidelines or any hierarchy in terms of pharmacotherapy. And these non-invasive measures could be simply looking for an ABI, which is very, very simple. It can be done on the bedside. Most of the clinics are doing this as a routine practice. It could be a coronary CT calcium score. You have seen Caucasian versus Asian patient, they are different. So coronary calcium score is much higher and it comes much earlier in Asian patients as compared to the Caucasian patient. This is how you do a scoring. No plaque here, score is 0. Non-calcified soft plaque, then there is a mixed plaque, and then you have a advanced calcified plaque where calcium score is more than 100. And this could sort of predict that increasing cardiovascular mortality. So if you are not having any plaque, the risk of a cardiac event or mortality is much lesser as compared to someone having an advanced or mixed or a calcified plaque. Then another non-invasive techniques are looking for flow-mediated vasodilation as a marker of endothelial dysfunction. You could look for pulse wave velocities to predict not only PVD, but also it could be a predictor of coronary artery disease. Look for augmentation index. Various vascular profiles are available these days, which you can use in your clinical practice. You can also do a carotid intima media thickness evaluation also. And this is what we did as early as I think 2005. We presented this data in RSSG and it got subsequently published also. We did a flow-mediated vasodilation as a marker of endothelial dysfunction in obese, diabetic as well as coronary artery disease patients in North Indian population. And to my surprise, all these evaluation I have done on bedside myself. I was surprised that except the group which was lean and thin ward boys, all almost less than 25, all other group, whether they were CAD or diabetic, CAD and diabetic or even obese group, they had impaired flow-mediated vasodilation and normal was close to 11.26%. So that gave us an insight that even before the onset of type 2 diabetes, at a stage of obesity or pre-diabetes also, you could have an impaired flow-mediated vasodilation, which could be taken as a marker of endothelial dysfunction. This paper we presented this year in ACE itself. What we have done is we have looked for augmentation index and we have sort of devised a formula that there could be a clustering of metabolic risks, which could be an approach. It could be used as a novel tool for risk stratification in clinical practice. This was a data on 300 patients, and this ACE in May 2019. Then newer techniques in detection of subclinical atherosclerosis are also getting popular. These could be echoparticle image velocimetry, or it could be MRI velocimetry, which are looking for not only velocity profile, shear rate, shear flow stress on the arterial wall. So based on that information which you get from the arterial wall, you could predict that this patient might be having an advancing atherosclerosis, and this could be very, very important in clinical practice. Coming to the last point, how we incorporate all this information or risk stratification into the clinical practice once we go to the guidelines. And not very late, 2018 itself, ADA said that treatment recommendation for uncontrolled type 2 diabetes with hypertension. So they said that if you have a blood pressure more than 140/90, start one agent. If patient has albuminuria, this has to be either ACE or ARB. If there is no albuminuria, again, if you start with ACE or ARB, in diabetic it will be better. If you have blood pressure more than 160/100, straightway you can start with 2 drugs. One of those drugs has to be ACE or ARB. Second drug could be either a calcium channel blocker or a diuretic. Follow these patients for blood pressure control. If pressure is well controlled, fine. If it is still not met or targets are not met, that means less than 130/85, maybe you go on adding another drug, which again could be from the classes like ACE, ARB, CCB and diuretic. And still if blood pressure control is not there, ideally these patients should be evaluated for uncontrolled hypertension and should be preferably referred to a cardiologist for better assessment. Then it also talked about the lipid target, that we should use high dose statin, which is recommended for every type 2 diabetic patient who has history of clinical atherosclerotic cardiovascular disease plus have an additional CVD risk factor. But if there is only risk factor, no established cardiovascular disease, then maybe you can go for a moderate dose of statin therapy. So ACC 2019, see a cardiological society, American College of Cardiology, 2019 addressing a algorithm in terms of choosing a anti-hyperglycemic drug as a primary prevention for cutting down cardiovascular risk. They are not talking about only for statin, lifestyle modification, diet, exercise, everything of course has to go, but they say that there has to be an aggressive treatment for CVD risk factors, so that assessment has to be there, what I have already talked to. And once these are there, once there is an evidence of established atherosclerotic cardiovascular disease or MRF, multiple risk factors, and if HbA1c is more than 6.5, that is the time not only you start metformin, continue with that. If HbA1c comes less than 7, continue all these. If HbA1c still remains high or control in terms of HbA1c is not there, that is the time you should look for all of these CV risk factors and then try to use or choose a drug like SGLT2 inhibitor or GLP-1, where evidence is great in terms of reduction of overall 3-point MACE after metformin. So today we are not talking of choosing an anti-hyperglycemic drug. We are talking of choosing other therapies in diabetics to cut down overall cardiovascular risk. We need to address dyslipidemia. We not only need to address hyperglycemia and insulin resistance, both into adipose tissue as well as muscles and into the liver by choosing various drugs. We are also talking of antiplatelet drugs to cut down overall ACS event, and we are also talking of reducing that atherosclerotic or that process which is going on or endothelial dysfunction by choosing drug like ACE, ARB, or maybe calcium channel blocker. So approach to decrease vascular risk in type 2 diabetes today is not only getting a glycemic control close to 7 as per AD or less than 6.5 or close to 6.5 with ACE guidelines, starting with metformin, looking for drugs like SGLT2 or GLP-1 analog, which have the greatest evidence to cut down 3-point MACE. Continue with lifestyle modification, smoking cessation, control of hypertension. I've told you American guidelines talking 2018, talking about control of hypertension in diabetes, which is very, very important by combination of therapies and using high dose statin whenever required. So 2019 guidelines said that first line after lifestyle modification has to be classically metformin until unless there are contraindication or intolerance to metformin. If you have an established atherosclerotic cardiovascular disease or presence of CKD or heart failure, obviously first option will be either GLP-1 analog with CVD benefit proven or SGLT2 if EGFR is inadequate. If EGFR is adequate, but well with credence data now we are wiser that SGLT2 can be now used, although off-label till now. We are already using it till EGFR 45, but you can continue till 30 also. So this makes a wonderful combination after metformin. But well, those patients where you don't have an evidence of established atherosclerotic cardiovascular disease or CKD, but the risk of hypo is very, very high, again you should choose drug like GLP-1, SGLT2, maybe TZs or DPP-4. But where there are compelling need to minimize weight gain or an attempt to reduce weight, obviously, again, you'll choose a drug like GLP-1 analog or SGLT2. But well, if cost is a factor, not every patient, even if prescribed, will use SGLT2 or GLP-1 analog. There you could choose drug like sulfonylurea or TZs like pioglitazone, which is fortunately very, very cheap in our country. Let's come to finally the evidence, whether there is an evidence to say that in terms of hierarchy, what I said, choose a drug after metformin like GLP-1 or maybe SGLT2, and these are the meta-analyses which are available with SGLT2 in terms of CV outcome on 3-point MACE. Empiric said that there is a reduction by 14% in 3-point MACE, which was p-value-wise significant, and all three components were significantly reduced. Canvas said that again there is a reduction by 14%, but individual components didn't sort of statically become significant as far as p-value was concerned, but this 14% reduction in Canvas program with canagliflozin was also significant. And the recent DECLARE-TIMI trial said there is a 7% reduction in 3-point MACE. Well, p-value wise it was not very, very significant. Now we try to do a dissection of the same data, whether in terms of 3% 3-point MACE reduction, if it is different for those patients who have already evidence of atherosclerotic cardiovascular disease, because EMPA-REG had all 100 patients who had 100% patient who had established cardiovascular disease. Canvas program had 65% patient, and Declare TIMI had only 40% patient who had established cardiovascular disease. So even then, there was 14% reduction in EMPA-REG, 18% reduction in 3-point MACE in the Canvas program, and in Declare TIMI, it was 10%, which was p-value-wise significant. But if you see that with the presence of multiple risk factor in terms of 3-point MACE reduction, none of these drugs, whether you talk of EMPA or CANA or DEPA, they made any difference, because p-value wise they were not significant, and that hazard ratio was only 1. But if you take the composite CVD as well as hospitalization for heart failure with the group which had established atherosclerotic cardiovascular disease, again in EMPA-REG there was a 34% reduction. In the Canvas program there was 23% reduction, and even in the Declare TIMI trial, two composite primary endpoint, CVD as well as hospitalization for heart failure in the presence of atherosclerotic cardiovascular disease, that was down by 17%, which is very, very meaningful as far as this meta-analysis is concerned. If you look for only heart failure reduction in the presence of atherosclerotic cardiovascular disease with SGLT2, again, it is very, very impressive, almost 35%, 32% and 22% reduction in risk of hospitalization for heart failure, all those patients who have established cardiovascular disease. So that brings us to a changed pharmacological approach in today's era. In 2019, we say that metformin has to be the first line option because it has very high efficacy, no risk of hypoglycemia, no weight gain. Actually, you might end up with losing some weight, you may shed some weight. If patient has established cardiovascular disease, there could be potential benefit, but this information is based from our original UKPDS data as early as 1998. There have no CV outcome trials on metformin, but in terms of cost, there is an advantage. It is the cheapest drug. It is an orally available drug. It may not help in terms of reduction of renal composite endpoints, but it could be neutral. But with SGLT2, you have all the advantages. Great efficacy, weight loss happens. EMPA and CANA has already proven that if you have established cardiovascular disease, there is going to be a 14% reduction in 3-point MACE. Cost is of course high, it is orally available drug, but if you talk of renal composite endpoints, whether it is EMPA, DEPA or canagliflozin, there is a significant reduction, and Credence data said that 30% reduction in renal composite endpoint in someone who already has reduced eGFR up to 30. So even if patient has falling eGFR and you tend to continue SGLT2 inhibitor, you may actually check the progression of CKD also by at least 30%. So to end today, when we talk of a drug choosing based on the atherosclerotic cardiovascular risk, ideally it has to be a drug after metformin, either a GLP-1 analog or one of these SGLT2 inhibitor, because there is a huge amount of evidence, and that is how American College of Cardiology, again going back to the cardio, said that novel therapy for CV risk reduction in type 2 and established atherosclerotic cardiovascular disease could be, of course, lifestyle modification, which we need to continue, statin, antihypertensive therapies, look for drugs like GLP-1 analog or SGLT2 inhibitor, initiate a clinician-patient discussion. Even if patient is not able to afford, and you try to convince them that today if you spend on these drugs, maybe tomorrow you won't have to spend on complication, because cost of handling complication could be as high as 4 to 5 times. So many of the patient may opt these drugs, and then one of these drugs could make difference in terms of overall progression, because as I said earlier, CV risk continuum in type 2 diabetes is a sort of, it's an ongoing phenomenon. It starts much earlier than anticipated before the onset of disease by almost 7 to 10 years. And subsequently, after the onset also, this risk goes very, very high, and you could make a difference in terms of reduction of 3-point MACE and progression of atherosclerosis in these patients with drugs after metformin, which could be either GLP-1 or it could be SGLT2 inhibitor. Thank you very much for your patience listening. If you have any questions, I'll be more than happy to answer that.